Good evening and welcome to the Child Neurology Foundation's 2021 Patient Advocacy Summit. My name is Katie Henches and I'm the Director of Programs for the Child Neurology Foundation. This is our inaugural Transition of Care Patient Advocacy Summit, and we believe that the patient voice and experience is an integral part of a successful transition from pediatric to adult care. This summit focuses on centering those voices and experiences, ensuring that these young adults and those who support them have the knowledge, tools, and confidence to be able to make the process successful. In addition to this summit, CNF offers other resources in the transition of care space, including a toolkit for young adults, their caregivers, and healthcare providers to begin and to encourage the many discussions required to have a successful transition of care. These are available in English and Spanish, and the link to where they are located on our website will be dropped in the chat. These resources and our summit would be impossible without our partners. We're able to put on summits like this for free today thanks to generous support from our partners in transitions of care, including Acadia, Biogen, Eisai, Genentech, Greenwich, and Zogenix. And we hope that if this session resonates with you or that you find it helpful in advocating for yourself and you are able, that you think about making a donation to the Child Neurology Foundation. It would be so helpful in continuing our efforts to provide first-class programming and education like this summit to the entire community. If you're interested, you can make a contribution and a link will be dropped in the chat. All right, so on to our panel tonight. It's entitled Racism, Discrimination, and Other Adverse Childhood Experiences and Their Long-Term Effects on Health Outcomes and Care. We want to pause here and acknowledge the holiday that was observed at a federal level for the first time this weekend, Juneteenth. While Juneteenth is a celebration of freedom, we must also sit with the reminder that this day is too about delayed freedom, 2.5 years after the issuance of the Emancipation Proclamation and even after the end of the Civil War for enslaved people in Texas and the unfulfilled promises of equality and justice still today for American descendants of slavery. Every one of us has a role to play in working toward a fully inclusive and anti-racist world where all children have every opportunity to thrive. We hope that panels like this one that highlight how that delayed justice plays out in the health of Black people and other people of color empowers us all to find our own path forward in that work. Dr. Magdalena Zaflarski is an associate professor and the director of graduate studies in the Department of Sociology at the University of Alabama in Birmingham. Her passion and research has always been in addressing the health needs of those in the most vulnerable populations. She has published studies in health and social science journals on topics ranging from racial disparities in HIV to quality of life in epilepsy and mental disorders. Dr. Brandy White is an associate professor at the University of Kentucky. Her scholarly activities focus on understanding the influence of the social determinants of health outcomes for medically underserved populations. She has a master's in public health from the University of Minnesota in community health education and a PhD in health and rehabilitation science from the Medical University of South Carolina. India Smith graduated with a Bachelor of Arts in Neuroscience from Boston University in 2018, where she worked in research focusing on neurobiology in children aged 6 months to 6 years. In 2020, she graduated from the Master's in Medical Sciences program at the University of Kentucky. Currently, she's a research coordinator at UK, who along with her peers aims to alleviate health disparities by adapting and creating tailored interventions for under-resourced populations. Our moderator for this panel is Lauren Brigham. Lauren is a program coordinator at the Child Neurology Foundation, supporting programs related to transitions of care, telehealth, and bridging the digital divide. Before we get into their comments, I want to go over some housekeeping things. This panel is being recorded, and the recording will be made available to all registrants on the password-protected hub you received access to upon registration. Please remain muted while the panelists are speaking, but there will be designated time for you to unmute yourselves and ask questions to our panelists at the end of the event. Please indicate that you have a question by using the raise hand button under the reactions button on the bottom of your Zoom screen. You're also welcome to ask questions, and you are encouraged to provide comments anytime by using the chat feature. If you feel comfortable doing so, please leave your video on, but if you have distractions or you would prefer to leave it off, that's okay too. So with that, I would like to turn it over to Lauren.
Thank you, and thank you to all of our panelists and all of you all for being here. I'm going to hand it to Brandy and India to kick it off for us.
Good evening. Sorry for the technical difficulties. Was a little slow with switching things around there. And I do apologize if you all hear a little dog barking in the background. That is Max, little mighty Max, our Yorkie, who feels that he needs to always protect the house. So, good evening, everyone. Thank you for attending this presentation on patient advocacy. Today, Indy and I will be talking about privilege and the social determinants of health. And we're gonna talk about privilege in a different way that some may be used to talking about privilege. Oftentimes when we hear the phrase privilege, people think of white privilege, and privilege is so much more than that. And we'll get into that as we walk through our discussion. We do want to note that we do not have any disclosures to report. Because our conversation, I hope that we can have an open conversation, may discuss some things that we feel uncomfortable with. I know I'm definitely going to be uncomfortable, I'll admit, with some of the topics, but I do want us all as a group to agree to be respectful of our individual differences. Raise your hand or place questions in the chat. Feel free to engage with us throughout our talk. When speaking, if you're comfortable, please enable your video and also remember to enable your audio. And because these are challenging topics, please choose to be courageous. It's really important as a health equity researcher and as an educator for us to have these types of discussions. And I thank the Child Neurology Foundation so much for providing this platform, because oftentimes we don't have that space. So I want you to use this opportunity. It's a positive space to learn, grow, and change. As I talked about comfortability earlier, being uncomfortable is okay. We ask that you have an open heart and open mind. Understand that people's feelings are legitimate. If we do talk about some things, you may not experience them, but others may. And also with that experience empathy and speak up against injustices. Because a lot of things that we're talking about really focuses on advocacy, sorry about that, and patient advocacy. And with that, you inherently have to focus on justice. So let's get into the conversation about privilege. What is privilege? Well, if we go by the Webster definition of it, it's a special right, advantage, or immunity granted or available only to a particular person or group. Can you all think of any examples of privilege in your own life? Do we have someone in the chat? Education, that's a big one. Access to quality education. And a lot of times when we think about education, if we're talking about community, public schools, it really depends on the type of community that you're talking about. So if it's a low income community, oftentimes we find that the education quality is less than optimal. And we find the opposite with more higher income communities. They're able to optimize their educational quality, which we'll talk about later, also includes whether or not you're going to have access to good jobs, as someone pointed out, if you're going to have good health insurance, as someone pointed out, with healthcare access, and then just your level of income, what you have available. So this is often a topic that we bring up with students, undergraduate students in our classes. And throughout the years, we've collected their comments on it. And what they've said to us when we discussed privilege, they said, privilege, to me, it means having what others do not have, having more chances or opportunities or enhanced quality of life. And when we think about privilege, as you all already pointed out, there's not just white privilege, that's just one type of privilege. There's also a significant amount of privilege that comes to those that have socioeconomic advantages, that have certain types of health insurance. So if we think of someone with private insurance versus someone with Medicaid or Medicare, there are differences in how healthcare clinics and hospitals view those types of plans. Someone's ability status, that can be a privilege. Someone's parent's profession, if you have a parent who's a physician or a healthcare provider, you have a lot of privilege when it comes to your health literacy and being able to understand that and have someone to go back to. Gender identity is also a privilege for those of the majority, as well as sexual orientation for the majority, with heterosexuals being the majority, and then race and ethnicity. So less represented communities, such as the communities of color, they include Black or African American, Hispanic or Latino, as well as Native American and Asian and other minority races and ethnicities. Are there any comments or questions about that? Okay, so let's get down to the nitty-gritty. When we talk about privilege and the social determinants of health, we first have to understand what affects health. So what are some things that you all see on here or that you don't see on here that affects health? Just yell it out.
Age.
Age is a big one. Can you change your age? Do you have any effect on your age?
Nope.
Can I choose to be younger?
I wish, I wish I could, or older, but no.
What about genetics? Do we have control over that? No. Our sex, and here we're discussing biological sex, female or male, that we have no control over, and that's going to affect us. Gender identity. So we're bringing in the whole, we talk about gendered identity. You see in the news how a lot of members of LGBTQI communities face a lot of discrimination. And that's really getting into our social society. What about things that we do somewhat have some control over, but we really don't if we think about it, that also affects our health? Can I affect how helpful my friends will be or my family members? Right? Can I? Not really, right? I can choose friends who are supportive. That doesn't always help out. Experiences of discrimination can have a big impact on our health, and we have no control over that. Where we live, that being our physical environment, that's something else we don't have control over, especially children and young adults. When we think about our physical environment, we also think about our social environment. So our physical environment can be toxic in many ways. We think about lead in drinking water, which we'll talk about in a little bit. Flint, Michigan, all those children who are going to have neurological conditions because of that excess lead levels that they experience because of the contaminated water. Access to healthy foods, some people can't control that. And if you've ever heard of something, they say that you can take your zip code and you can find out your health status just by looking at your zip code. And that's because where we live is often dependent on the types of resources that we have. So keep that in mind as we go through the presentation. So those things, such as our physical environment, our social support, our experiences of discrimination or lack of experiences of discrimination, These are the social determinants of health, and these are conditions and environments in which we are born, live, learn, work, play, worship, and age that affects not just our physical health, but also our mental health and our overall quality of life. So what causes early death? We think that it would be genetics, right? Just genetics alone. But from looking at this table, what do you all see from this pie chart? What has the most significant effect on our health? Someone just provided a really awesome tool from the Robert Wood Johnson Foundation that you can look up your zip code and see how life expectancies differ. Thank you so much, Jessica. But is anything alarming in this pie chart?
Individual behavior.
Yes, individual behaviors. And I used to be a quit smoking counselor for people experiencing homelessness. And when we think about individual behavior, you know, you think, well, smoking, people smoke because they want to smoke, you know, all those people that smoke, it's their fault. And really, when you think about smoking, smoking is a response to chronic stress. It's a response to chronic stress. So if you think about that individual behavior with smoking and chronic stress, which can be related to things in your social and environmental factors, such as whether or not you have housing stability, whether or not you can afford to pay for your child's healthcare or your own healthcare, whether or not you can get to your healthcare appointments because you may not have access to a car or public transportation, like in central Kentucky and Lexington here, is really poor and it takes you an hour and a half to get to your doctor's appointment versus having a car, which would take just 15. I mean, these are all things that contribute to our health. And if we're disadvantaged in any of these areas, it can have an impact on early death. So, upstream and downstream factors. When we talk about the social determinants of health, we like to think of the social determinants as those upstream factors that are really the fundamental causes of a lot of health outcomes we see. So this is excluding those that may be related to genetic conditions. However, if you are disadvantaged in certain areas, these factors, these social determinants, can exacerbate the symptoms or worsen the symptoms of whatever condition you do have. And I'll give you an example of that in a little bit. So going back to that lead poisoning example in Flint, Michigan. In the case of Flint, Michigan, it's a great example of how the social determinants of health work. Starting out up here, you had a facility where their pipes, when the water was switched, the pipes and everything it was very poor quality, it was deteriorated, and it caused lead to leach into the water. So this is what's happening upstream. What happens downstream? And this was their drinking water source. What's going to happen downstream? They're going to drink the water, right? But this is contaminated water. And what do we know about lead? There is no safe level of lead. And if we think about children who are extremely vulnerable during that early development period, that can have significant impacts on their quality of life, as well as their physical and mental health as they age. So I want to give you all a personal story. Are there any questions before I get started with the personal story? You all are so quiet. I'm not used to this. I keep going back and back to the thumbnails.
We're enjoying it.
Okay, so this is a personal story. I lost my mother recently to cancer back in December. And a close family friend, I'll say her name is Jennifer, She has a genetic neurological condition, SCA type 2, that affects her motor skills. And so she has involuntary trembling and muscle stiffness. And as she ages, it's going to get progressively worse. So something about Jennifer. Jennifer grew up in the foothills of Appalachia in North Carolina, in between Hendersonville and Winston-Salem. She's a Black woman. She grew up in a single family household, which means that there was limited income. They lived in a low income area, extremely low income, where she was regularly exposed to violence, which we see in a lot of our low income communities. There were a lot of limited employment opportunities. And she also didn't get the best education. So she ended up dropping out of high school when she was 15. She got a job, not the best job, but she was working, right? This was before her condition worsened. She had limited healthcare access. At this point, she was uninsured. There were some times when she had a better job where it did provide a little insurance, but she was always underinsured. So when it came to her condition, her SCA type 2, she really put off her healthcare needs because she just couldn't afford to pay out of pocket. Eventually, an incident happened at a job she was working at. It was a bakery where she ended up falling and hurting herself. And that's when she was able to get disability. That was $600 a month. She's an adult with no children. So ironically, for adults, especially young adults with no children, it's really challenging for them to get the resources, financial resources that they need. So she always had limited transportation because of either not having a car or she needed her car at the time to be repaired. And she had severe unstable housing conditions. Oftentimes she was sleeping on a friend's couch. We would always offer our home to her, but she decided to stay in North Carolina closer to friends. Until in mid-March 2020, she fell down some stairs at a house that she was staying at. She broke her ankle in 2 places, had to stay off her feet for 8 weeks, and she needed intense rehab. And they placed her in a nursing home because she didn't have anyone really to take care of her. So what was going on in mid-March 2020 in nursing homes? This was a young adult. The pandemic. She was relatively healthy and she was placed in this nursing home. So we found out about that, and thank God we convinced her to come here and stay with us. And she really served as a companion for my mom throughout that period. But I look at her life. She's a Black woman. She's experienced several experiences of sexism as a woman, classism because she lives in poverty. She's heard comments about, she's heard nurses, healthcare providers state, oh, well, let's not give her any painkillers because we know that a lot of Black women are they're drug-seeking adults. Those are stereotypes that she faces. So when we talk about the social determinants of health, I want you to go back to Jennifer's story. And let's think about what differences or similarities you have with her story. And then together, how can we work to support underserved groups like this? So with Jennifer's story, we can clearly see the social determinants of inequities. But when we add that privilege onto it, you can see that for those that are socioeconomically disadvantaged, that means they don't have any socioeconomic privilege, versus if they did, that would be wealth. She has limited poor healthcare access versus adequate healthcare access. Times of homelessness versus stable and safe housing. And imagine what impact that has on your mental health. And then overall, Jennifer, she's going to have a lot more experiences she's going to have a poorer quality of life compared to someone who doesn't face these same barriers. So, as we talk about the social determinants of health in detail, we're going to look at our own privilege. So we're going to imagine we are in a race to get our dream job, whatever that might be. It could be writing on an island in Hawaii, writing poetry, and you get paid for that. Each of you will be rated out of 10 points. But before the race even begins, you all have to complete a pre-job application based on a series of questions that provide a score of -1 or +1. And you decide whether that statement applies to you. There's no right or wrong answer. Your pre-job application score will be used as a base before you start your application. So throughout this, please keep track of your score. You can just write it down on a little piece of paper. Are there any questions before we get started with this? Indy is going to join us in a little bit. No questions? Okay. So to start out, let's have some initial questions. Did you start school speaking a language other than English? If yes, deduct 1 point. So we start out with 0, then you have -1. If that's a no, add a point. Did you ever attend a private school? If yes, add 1. If no, subtract 1. Did your parents own their house? If yes, +1. If no, -1. So for me, after doing these initial questions, I have a score of 3. Does everyone see how that works? Okay. So the next couple of questions are looking at socioeconomic status. Have you ever inherited, or are you going to inherit money or property, including large lots of land? If yes, add 1 point. If no, subtract 1. And this is from that same score from the initial questions. Do you have immediate family members who are doctors, lawyers, or other professionals? And then you can see the scores on there. So these 2 questions are really getting at socioeconomic status. And a lot of inequities that we see are related to socioeconomic status. Socioeconomic status encompasses education, income, and one's job. Healthcare access is related to a lot of this if we think about our occupation and what type of insurance they provide. But something that we do know in the evidence is that people in the research is that people with the lower socioeconomic status are at a higher risk for serious illness and early death. And material or psychosocial factors such as stress, racism, sexism, having money or limited money can contribute to higher risk of illness and early death. So socioeconomic status as a social determinant of health has a big impact on our quality of life. Another determinant that India is going to talk about is chronic stress. and I'll be quiet right now.
Hello, everyone. I'm India. I'm going to take over for this little section. Before I go a little bit deeper into chronic stress, I'm going to read out these 2 questions for you to continue counting up your points. So in general, can you avoid communities or places that you consider dangerous? So give yourself a point if you say yes, take away a point if you say no. The next one, do you experience anxiety or fear regarding police or any law enforcement based on your race or ethnicity? Yes, a score of -1, no, score of +1. And Brandy, if you could do the next slide for me, please. So stress can kind of be thought of as a blanket term nowadays. Everyone is under stress, like stress is a buzzword for things. Like you can think, like there's a lot of things that can cause you stress, but some people don't really know the physical manifestations that like stress has. The fact that stress actually changes your body and can affect many parts of your life. Right here, this picture is just showing a few thoughts that people can think of that can cause them stress. A big change in your life can really continue to put you in a circle of anxiety. And since life is continuous changes, and for others, obstacles that come with those changes, some of the stress may feel like it never really goes away. So stress can affect your sleep. Going back to the question about feeling like you're in danger, an environment that you feel that you can avoid if it's dangerous, sleep. You cannot feel safe in your home, you might not get great sleep. Cortisol, which is a stress hormone, can really affect your sleep. It's higher at certain times of the day. If you have a very stressful job where you're working overnight and you can only sleep during the day, that's causing you stress. It's a vicious cycle. It can affect your quality of life, your weight, mental health, relationships with other people, your physical health. And a big thing that I learned, stress can cause you physical pain, can hurt to be stressed. So if you could do the next slide for me, please. A couple more questions. Do you commonly see people of your race or ethnicity on television or movies in roles that you consider to be degrading? So take 1 away for yes and add 1 for no. And the next one, were your ancestors forced to come to this country or forced to relocate from where they were living, either temporarily or permanently, or restricted from living in certain areas? A yes, take away a point. No, add 1 point. You could do the next slide. So tying in for that, some people can't control the stresses that are placed upon them. I have written here, dealing with stress can feel like juggling plates, but some start with more plates than others, and some plates are impossible to put down. People add plates, everything can really happen. The body is about balance. Stress is about trying to manage your environment in a balanced way. And for when you look at racism and you look at the fact that that's woven into the structure of our judicial system, our healthcare system, just access to everything, it's so hard to manage the stressors that really you can't control. So I have down here too, looking at school environment. We talked about access to education, feeling like your teachers don't believe in you, feeling like you don't have any way to have a peer support. I know from a personal story, when I was at Boston University, we had groups of people that shared answers, shared test questions, but if you weren't in a certain group or a certain level or didn't come from a certain standard, you weren't involved in those study groups and you didn't have that in. Other thing with relationships, racism, and finding like love, companionship, everything just can add to your stress, and that can really make you sick. So you can do the next slide. And I'll turn this one back to Brandy.
So the last determinant that we're going to talk about, social determinant, is adverse childhood experiences. I didn't provide, we don't have a score for this, but I just want you all to be aware of these. And these are negative childhood experiences that really have a lifelong impact on our overall health. So this can be, they usually look at, they consider adverse childhood experiences occurring before the age of 18. It can be an experience of physical abuse, emotional or sexual abuse, physical or emotional neglect, household dysfunction, including having a parent or a caregiver who has a mental illness, having a relative who's incarcerated living in the home, a mother who was treated violently, or substance abuse, and as well as divorce. So with ACEs, they're also known as ACEs, there's a lot of evidence that it contributes for those that have experienced one or more of these adverse childhood experience ACEs. They often have, when they're adults, they miss work. A lot of them experience drug use, and a lot of that's related to coping, chronic stress, and your coping strategies. So smoking, alcoholism, drug use all come into that. When we talk about our physical and mental health, having ACEs, we see that those that have experienced multiple ACEs as adults are often severely obese. They have diabetes, depression, COPD, stroke, a lot of those chronic conditions that are long-term conditions such as heart disease. Something else that we know are individuals who have an ACE, young adults who have an ACE, are at a greater odds of reporting a mental or behavioral disorder. So it's really important when we talk about equity and the social determinants of health and privilege, the role of these ACEs, because these ACEs supersede racial boundaries. So I wanted to see if anyone wanted to talk about their scores now. We're done with the job application, the pre-job application, that is. So does anyone want to share their score?
It was pretty high.
Yes. And I want you all, this is something that's really important when we talk about privilege. There is nothing wrong with having privilege. Nothing wrong with having privilege. I'm a Black woman with a PhD. I have a lot of privilege, especially in certain areas. Other areas, I don't have privilege. But most of us have some form of privilege. So for those that have privilege, it's really important for us to understand how that plays with our health outcomes and our ability to maneuver through different systems, but also how it impacts those that don't have privilege. And think about how we can be an advocate for them, especially when it comes to patient advocacy and justice. So I just have a couple more things to talk about before we pass it over to Magda. She's really going to focus on next steps, but I want you all, this was just a brief snippet of the social determinants of health. Please continue to be a lifelong learner. Look up information on your own, and after you know this information, make an informed decision. Another way that we all can play a role is being a mentor, especially to those that are less privileged than us. And then really being an advocate and finding ways within your own network or your own foundations that you're a part of. How can you be an advocate for those that are part of your patient community? And how can you all work to achieve equity and justice? So here's our information, and I'm going to pass it to Magda. Sorry for talking so long.
So I'm going to try to share my screen now. Can you see it? Thank you.
Yes.
Okay, so thank you, Brandy, for this excellent presentation. As a sociologist and teaching sociology every day, I definitely engaged a lot in those conversations about the social determinants of health. And also my research on health disparities is driven by the framework introduced many decades ago now by the World Health Organization and the social determinants of health. And I really liked the examples that you gave. I think they brought really a lot of these points home for me and for others here. I'm going to give a very brief talk today, basically just touching on a few points that we can maybe take and onto our discussion. I don't have a lot of time today, so again, hitting some points here. A lot of what I want to say comes from my own research on racial and ethnic disparities in general, and also specifically on epilepsy. And I have also been involved in some studies of stroke that have shown immense disparities in outcomes after stroke based on race and ethnicity. But primarily, I'd like to talk about epilepsy because that's where my current research is. I'd like to start with a major report that came out from the Institute of Medicine in 2003. It was a seminal report for the first time looking comprehensively on how racial and ethnic disparities in treatment are produced and how aspects of the clinical encounter between the patient and the provider contributes to such disparities. A panel of experts conducted this very comprehensive review to identify specific gaps in treatment, basically showing that racial and ethnic minorities receive less care and receive worse quality of care within our American healthcare system. In addition, this report identified things about patients and providers, their attitudes, expectations, and behavior, which contribute to disparities in health and healthcare. At the end of the report, there are specific recommendations for what we can do with the healthcare system to improve the situation, to reduce and eliminate disparities in healthcare. Some things were suggested, such as improving medical care financing, allocation of care, make it more equitable, especially for immigrant populations. There was a suggestion of availability of language translation that was needed. Community-based care was needed to be broadened, and other things. In addition, there was an emphasis in the report on cross-cultural education, especially of providers, but also within healthcare systems in general. And finally, the experts pointed out that we have insufficient data about health and healthcare disparities, and we need more research. So keeping this in mind, one of the populations that I study more in depth are people with epilepsy. And so looking at research evidence that we have, which I might add is limited, we still don't know enough about disparities in epilepsy. But what we know so far, we know that racial and ethnic minority populations bear a disproportionate burden of epilepsy. Looking at the occurrence of epilepsy or seizures, what we see is that the prevalence rates are higher in Blacks than whites or Hispanics and Latinx for specific ages, 20 to 59. So in some other ages, we don't see that disparity, but for this age group, we do. In addition, we also know from research that Native Americans and some Hispanic and Latinx groups have higher prevalence of epilepsy than whites and non-Hispanic Latinx or Latinx. Finally, non-whites have higher incidence of status epilepticus across all ages, which is a very serious condition and leads often to death. So that's one aspect of epilepsy, the occurrence of seizures. But then looking at healthcare disparities, at epilepsy care specifically, we also find certain disparities. And these are just examples, so I'm not able to give you a comprehensive picture. But something that we know is that whites have lower hospitalization rates for epilepsy than other groups, especially Blacks and Hispanic and Latinx. We also know that Blacks are less likely to receive advanced treatments for epilepsy. such as epilepsy surgery. And there's more and more actually evidence in this area that is emerging, because epilepsy surgery has been shown in some groups of patients with epilepsy to be very effective in reducing seizures or eliminating seizures completely, and has a tremendous impact improvement on in quality of life. So now you see certain groups are not able to receive this treatment and not able to, and will continue seizures perhaps because they are not able to get that treatment. Another example of disparity is access to anti-seizure medications. White children with epilepsy has been shown to be more likely able to fill prescription for anti-seizure medications than children from other racial and ethnic backgrounds. And again, these are just examples. Much more research needs to be done, because we actually have huge gaps in the literature, in the evidence, research evidence about where disparities lie, especially in terms of clinical management of epilepsy. But even with the evidence that we have, that obviously brings the question of how, where we can improve the treatment of people with epilepsy so that we can reduce the disparities that exist. Going back to that initial unequal treatment report, so what we know is that disparities in general exist at different levels. Some disparities exist at the provider or patient level or healthcare services level, where the services are being delivered. Others exist at what we in sociology call the macro level of the society, the larger context. So the healthcare system of how the health policy is made and what it is, and how healthcare is financed within a society. That's one aspect of it. And then even the healthcare system is then embedded within a larger social cultural context. So we know that whatever is happening with our culture and with other social systems that interact with healthcare system will make a difference for healthcare the services delivery. And then what happens specifically within healthcare systems, such as disparities, will arise maybe because of implicit providers' biases, or patients not having enough trust in the providers, patients from certain groups. So it is very important to look at the social cultural level, right? And there's so much talk recently about structural racism. It's embedded in all our social systems. And so structural racism generally is within itself described as a system, defined as a system in which public policies, institutional practices, cultural representations, and other norms work in various often reinforcing ways to perpetuate racial group inequity. Our goal should be racial equity versus inequality, right? And I think many people will agree with me today that the only way to actually get there, to create racial equity, is to become a non-racist society. Now, when we look at healthcare equity, what we want, our goal should be that the care received would be the same regardless of race and ethnicity, other things equal. So regardless of age, gender, specific conditions, and so on. The same thing for health equity. Our goal should be health outcomes should be the same regardless of race and ethnicity, other things equal. And only when we can achieve these kind of goals in terms of health and healthcare, and then also at the general level, societal level, we can achieve racial equity. You know, the same in education and workplaces and all other places in society. We need to find ways to become and practice anti-racist. And as I wind out here and would like really to lead us into the discussion is how we get there. How do we become anti-racist? And how do we build a non-racist society within which then we will have a healthcare system that is more equal and where we will eliminate health disparities? I think one thing we have to keep in mind, everyone has responsibility to build equity, including health equity. So like Brandy said, it's totally fine for somebody to have privilege, but recognizing privilege and engaging in building equity, that is something that we still have to learn to do as a society. There is a lot of research that shows in terms of health, if we can improve health of one group, then the whole society will benefit from it. And that's, for example, why many Western countries have national healthcare systems, because by equalizing access to healthcare, they're hoping everybody will have better health outcomes. And that's how health equity is built. In the United States, we don't have a national healthcare system, and access to healthcare is not equal. And consequently, the health outcomes are unequal. So we have more disparities than many other countries that actually have national healthcare systems. And so lifting up one group will help the whole society. That's what research tells us when we look at outcomes for individuals in different societies. And in terms of this structural racism, one of the, I think, prevailing thoughts these days is, as we actually look up to those people who tell us about what to do, is that we need to work on becoming anti-racists. And this book that I'm showing you on the slide, How to Be an Anti-Racist by Ibram Kendi, is becoming more and more kind of a guide for us about what to do. And I listened to Kendi talk in a health equity summit just about a week ago or so. And the basic message is, many of us, believe that, we need more equity and so on. But we have to act on it. If we don't do anything, if we just think that and not do anything, that we're still racists. So in order for us to become anti-racist, we have to act on it. We have to do something towards increasing equity and eliminating racism. One of the things that my institution is doing this week, starting with Juneteenth, with this national holiday, is for people who are willing to sign up for a program where every day for 21 days, everyone is doing something, acting towards becoming an anti-racist. And it could be reading an article or a book, watching a program, talking to someone specifically about the issues around race and ethnicity and diversity in general. And everyone is keeping a journal, and we're going to share these journals and collect these journals after 21 days. And it's a short period of time, but it's a start, especially maybe at an institution that has a long way to go, or for a population that has a long way to go, because maybe we are not educated enough and not being aware enough and so on. So it's a start. If we could have this kind of action taken across society, then there is more of a chance to actually bring about a change, right? So I'm going to stop here. I am happy to talk more about what's going on with epilepsy and also mental health, because as we know, many individuals with epilepsy have mental health issues. And so if there's disparity in receiving treatment for epilepsy, there will likely be a disparity in receiving treatment for mental health issues for those individuals. So those are linked. And also what we know generally is that, especially in terms of discrimination, something that Brandy mentioned before too, that has an impact on health outcomes, both physical health and mental health, over and beyond other factors, over beyond age and gender and socioeconomic status. So discrimination, this is kind of a social psychological factor that is embedded within social structure, which has structural racism, has impact on physical and mental health. And we can think about individuals with neurological disorders experiencing discrimination that is maybe intersectional, that is both something, racial and ethnic discrimination intersecting with discrimination of having epilepsy or stigma of epilepsy in society. And that would amplify the experiences of discrimination and stigma that would then have more drastic effects, perhaps on health and both physical and mental. So I'm going to stop here and we can talk about all these other issues in the discussion. And here's my email address if you'd like to have more information about my sources or research on epilepsy. And specifically, I'll be happy to talk to you after our talk today, or mention, or maybe we can talk about some of these things in our discussion today. But thank you so much for listening.
Thank you all so much for sharing your expertise with us. You guys have done a fantastic job of demonstrating how privilege can impact our care. So I think we only have time for one question and a brief answer. So I was gonna start us off with, how does privilege or lack thereof play out in adult neurologic care and transitions of care from adolescent to adult care?
Who wants to tackle that? I can tackle it. Some people want to add on. I think we have privilege in more than one area. So as I talked about the experience with Jennifer, she was in that transitional period. And something that we have to think about that with that transitional period, in my opinion, are the resources that are available, especially if we're talking about young adults who do not have children, because oftentimes the resources aren't the same. So we want to make sure that as far as social support networks, that's stable, looking at the social determinants of health, but also with privilege. I mean, if we have a young adult who is socioeconomically disadvantaged, and we talked about some of the barriers that they can face. And as Magda talked about intersectionality, if you have a young adult who has any identities that are perceived as being not a part of the majority, then that may make it even more challenging for them to navigate not just the healthcare system, but also society. Did anyone want to include any other things?
If I may add to what Brandy said, I think the transitional group struggles with, one of the things that they would struggle with is the advocating for themselves. I mean, at which point and where should they go after they leave pediatric care? There are very few transitional clinics, and it's not only true for neurological conditions, but also for some other conditions. So getting to adult care could be an issue if you don't have a doctor that proactively helps you get there to transition. And then what is needed also that the individual and the family needs to seek it, right? So advocate for themselves, asking questions, where to go and how to transition and so on and so on. And so what we know from research is that racial ethnic minorities typically feel less empowered and even have, not only being in a position, but hesitating, asking questions and getting the right answers, and then following up through the process. It's more challenging for racial and ethnic minorities. And then because it is an age transition, right? We still have young people who may not have enough knowledge about healthcare systems and how to, what steps to take to get to another clinic or to find somebody who will provide continuation of care. So there are age issues there as well. But I think primarily in terms of the patient, we need to empower patients more to advocate for themselves in this situation, and especially those from racial and ethnic minority backgrounds, and also educate providers and empower providers to do their work, to extend their work from clinical care to help them through these life transitions, sort of, in terms of ages that need guidance, basically, from professionals.
I want to
Do
add.
I have time to add on, or
India.
we over the time limit?
Can we have a couple more minutes?
Well, I don't need more minutes. I was just going to add on to this, like 30 seconds.
For it.
Okay. Yeah, I can't hear if she's saying yes, but I'm going to go. So what I was thinking about with privilege specifically in this time, I've thought a lot about young adults and mental health. Like mental health is very, very important right now, with not even just with the pandemic, but young adults go through things where they need to talk to somebody, need to find who to talk to. And one privilege is the ability to prioritize your mental health. There are so many things that happen where you can say, oh, it's easier than one person for someone else to say, I need a mental health day, or I need to do this for my mental health. You want to make sure, just like how Magda was saying about advocating for yourself, that you are showing how important your mental health is to you and making sure to communicate that. And I think we're in a space now where it's getting a little bit more accepted to really just give the answer of, I can't right now, I need a break. And when you're a young adult, just like you have to empower yourself, you can feel like you're silenced or shut down when you talk about your mental health, or you're being dramatic, but it's really important to use that and communicate that.
And I just wanted to add one thing, as Magda was talking, health literacy came to my mind, and health literacy is another social determinant of health. You know, whether you understand healthcare terms, and that can affect, as Magda was stating, whether or not you're confident enough to ask or question your healthcare provider. But I want us to remember that a lot of times that supersedes racial and ethnic boundaries. Something that I hear a lot from my underserved, low-income white students is that it's not, if they have low health literacy when it comes to occupation, they need a lot of motivation because they don't see anyone who looks like them. And I don't mean just race. I mean someone who may be a first generation student, the oldest of 8 kids, and this is their first time going to college, and no one in their family is a healthcare provider. So that's just something else to think about. And I'm done. Sorry.
No, you're completely fine. Thank you guys so much again for sharing with us and answering the question. And I wish we had more time, but these slides will be posted to the Summit Hub. So if anyone would like to follow up and email India, Brandy, or Magda, then you feel free to do so. And I'll pass it back over to Katie.
Perfect. Thank you. Thank you so much to Lauren and to our panelists. We really appreciate your insight, Magda, Brandy, and India. So on behalf of CNF and our communities, we're so grateful that you shared your time with us today. As a reminder to everyone on the call, CNF and our partners have resources on transitions of care available on our website. So the link has been dropped in the chat, and also on the password protected hub that you have access to for the Zoom link for this talk. Additionally, you'll be receiving an email thanking you for attending this talk with a brief survey in it. Please fill it out. We love to hear from you and hear your feedback about our events. And I'd like to thank our partners, Acadia, Biogen, Eisai, Genentech, Greenwich, and Zogenix, for their support for our programming. If any of you are interested in donating, you can go to our website. There's also plenty more Summit to attend. Please join us tomorrow, Tuesday, June 22nd at 7 p.m. for our upcoming talk, Dating While Rare, Finding Love on the Other Side of Transition. And thanks again for joining us tonight, and we hope to see you tomorrow. Bye-bye.